In this section, we're going to talk about the axial skeleton, part 3. We're going to jump right into the lumbar and sacral regions and start to talk about some of the differences that we see, and then also what the rhythm is like between that lumbar and sacral region. We'll also talk a little bit about the combination movement of thoracic mobility and lumbar mobility and how we measure that in function for our physical therapy world. Just a few fun facts. We, as Americans, over 80% of us will complain of some type of low back pain in our lifetime. I would actually say empirically that number is higher, meaning that in clinical practice that often it's not reported, but people are just used to now having some type of low back pain. This will be a very heavy population that we will see, and it can be one of the most rewarding yet most difficult areas to treat just because of the psychosocial component of back pain, and then also the arena of having now significant nerve involvement. Nerve pain can be very, very scary and hard to treat. And then it's also difficult because there are hundreds of different interventions ranging from acupuncture to Reiki. There's new bionotomy treatment, which I don't even know what that is, but there's just all of these treatments out there, and they're all focused on trying to help people with low back pain, all the way up until surgery. And there can be minimally invasive surgery, there can be pretty significant surgery where they're putting a lot of hardware into there. So just know we, as physical therapists, have a big job when it comes to treating patients with low back pain, and but it's a challenge, and it's a challenge worth taking on because you really can affect someone's quality of life. This should just be a quick review from anatomy, so looking at the articular processes of the facet joints and understanding the orientation of our facet joints. And if we really look at the way in which they're orientated, there's a preferential orientation to the sagittal plane. And these are strong attachment sites for lots of our ligaments and stability and muscles that come into play. You'll see on the superior facet that there's their mammillary processes. These are attachments for the multifidi and the medial intertransverse muscles. And those multifidi are very important in segmental stability. And we'll talk a lot about strengthening the transverse abdominis in conjunction with the multifidi. A lot of studies have shown that multifidi can actually turn off or be latent in providing stability for the spine. Understanding that there's on the inferior facet, there's a vertical and convex orientation, and they're orientated slightly anterior and lateral. And then the superior facets face posterior and medial. And then just taking a second look at that anterior aspect of each joint lies in that frontal plane to resist shear, and the posterior aspect lies really close to that sagittal plane. So we'll call this a biplanar orientation. We see that it's got this big vertebral body right here, and that's so that it can take a lot of those compression forces. And also we see that there's not a large foraminal area in this component. It's very tight in there, and so any type of disc bulge in there is maybe going to push out into that area. Still bigger than some of the other areas in our spine, but coming to understand that the vertebral body is really there to provide a lot of support. Okay, so let's just talk quickly about those zygophospophyseal joints or our facet joints. We can use those interchangeably. There's a unique orientation and design of L5, and it, instead of being shaped like L1 through L4 in that circular orientation, it's really wedge shaped, and even the disc is wedge shaped. This is so that the angle formed between the sacrum and now transitioning into the lumbar spine actually creates that lordosis. And we can see that, we can look at that, we'll look at that in a little bit more detail here in just a second. So here's our detail of that lumbosacral articulation. And taking a look, and especially on the picture on the right, we can see that if there's an increased angle right here, that we're going to have increased lordosis, curvature. This will be important when we talk about shear of the lumbar spine, because this changes the orientation of those facet joints, increasing shear on the facet joints. The angle is created by drawing our line through that L5-S1 and then a parallel line through the sacrum. Most of our normal degrees, about 30 degrees, but we can start to see with some pathology that if we get increased lordosis here, what starts to happen to these abdominals right into this area? And they start to become long and weak. Also changes the orientation of our discs. We start to get more compression in our discs in this area. So lordosis of the spine can be something that we really need to focus on improving posture within our patients. Let's move on and talk about just quickly the ligaments and fascia. So really, you guys will dive a lot deeper into this, into anatomy, and that's the expectation, is that you're getting strong foundation in anatomy. But just touching on quickly that iliolumbar ligament has such strong attachments, and it provides such stability of the pelvis into that lumbar spine. And it's really that transverse process of L5 to the more cranial part of the iliac crest, and so there's a lot of stability that comes from that, and it really helps stabilize L5. And we know that we just talked about that L5 is actually wedge shaped. It's at a greater angle than the other lumbar vertebrae, and so we need stability, especially as we talk about that pelvis is moving about the spine, and so it helps prevent that anterior displacement, which we can understand that if I am standing in normal lordosis, that I'm going to have an angle, but if I start to have increased lordosis, that this L5 is really going to shift anterior, and that can start to compromise those connective tissues in the area. But what we'll start to see is that there's actually compression onto that spinal cord and can create some of those radicular symptoms. I like this picture because it just shows you that the iliolumbar ligament is innervated and can also be a source of pain. And so these you'll see as referral points. And sometimes patients will complain of posterior iliac pain, and we'll think it must be because of the joint mechanics, but it also might be because of the either the increased tension placed on the iliolumbar ligament, or there might be compression if someone is listing to the side, meaning if they're shifting over to one side versus the other. It can also shift pain into the front part of the groin and out into the greater trochanter area. It's maximally loaded in the absence of muscle protection against flexion. So what does that mean? So if we all just sit kind of slouched right now, and we call that sacral sitting, that's when that iliolumbar ligament gets tensioned the most and gets placed as maximally loaded. And this can be, patients might start to complain of fatigue or deep ache into that area, and so we'll go right to the iliolumbar ligament for that. The thoracolumbar fascia of the trunk is one of those hot topics now in not only therapy, but in a lot of movement professionals, because we now have this beautiful understanding of how detailed this fascia, or it's really an aponeurosis, is, and all of the significant attachment sites into this. And I know you guys dive a lot deeper into that, into anatomy, so I'm going to leave that to you to make sure you understand that. But I just want you guys to just take a look at that anterior part of the thoracolumbar fascia. Really has those deep attachments into that quadratus lumborum, and that quadratus lumborum and thoracolumbar fascia in people that stand and sit throughout the day, that can get really, really bogged down and tight. This is already a thick layer of fascia, and it doesn't have a lot of that nice slide and glide, but it needs it. And so in someone coming in with back pain, it's really important for us to understand these connection layers. The middle also attaches into the quadratus lumborum, and then the posterior goes right into those transverse abdominis, which is what a beautiful setup we have, because that acts like a corset around our body. So if we contract our transverse abdominis, so if you guys all pull your belly button to your spine, if you put your hands on your ASIS and come about 2 fingers in, and you should be able to draw that belly button in and down, and underneath your fingers you'll feel that transverse abdominal kick on. The same time, there should be co-contraction of the multifidi, and it actually shows that now this provides tension into that thoracolumbar fascia, creating that corset. It supports that low back in full flexion, and it tensions that initiation of extension. So it's that elastic recoil that we've talked quite a bit about, that we want that, and we desire that, and we need that. So that's something that, again, in someone complaining of any type of low back pain, we're going to want to look at that. One of the other things that I think is really amazing, and such an amazing design, is that it attaches into the latissimus dorsi and then the contralateral glute med. So we get this big cross section. So when we go to design exercises, we want to tension from up top, include that latissimus dorsi, and then also gain stability through that glute area as well. We just talked about the connections to the TFL and the transverse abdominis, and showing here just the lines that we can see that this helps to really cause tension into that and provide a lot of stability. You know, the lumbar spine undergoes so much compressive forces because of the tension of those muscles around it, and so that the thoracolumbar fascia provides some of that extra stability that we need. Okay, let's jump into kinematics. So these are just questions I want you guys to keep in mind as we talk through just the next couple slides, thinking about what 2 areas of the body does the lumbar spine usually work in conjunction with to achieve range. So if you just bend forward right now, think about what really is working in conjunction with that. What plane of motion does the lumbar spine favor, and can you explain why? So tomorrow, or when we're in class and we're talking about this, can you get up in front of the class and talk about why? Where does the most flexion occur at? So when we go through our forward bending, where does that occur at? And then also, where's our largest range of lateral flexion occur? These are great things to just put in the back of your mind, keep it there, and then as we move forward and talk about patients and start to watch people move, we can start to go, okay, I want motion to occur here, and it's not. Now that might be part of their pathological condition that's occurring. So let's talk about that lumbosacral motion. So if we just bend forward, and I want you guys to put your hands on your hips, and you're just going to bend forward, but you're not going to move your pelvis. And let's just see how far you can get. And I want you to problem solve. Are you going through just normal lumbar flexion, or are you getting flexion of your thoracic spine? What's happening at your head? So, and then let's just kind of take a quick measurement. So for me right now, I'm reaching to the mid part of my knee. Some of you guys are going to just be limited by that hamstring tension and maybe not even be able to get through there. Okay, so now let's do that again. Stand up, hands on your hips. Now you're going to let your sacrum go with you as you reach down towards the floor. And so for me, at that point, I can get all the way down to the floor. So our largest range of flexion occurs at that lumbosacral joint. And so it's really key that that is a mobile area of our body, and that we can see that this nice arc of motion needs to occur for us to get all the way down to be able to reach to the floor. This is important in being able to pick things up, tie your shoe, and then just also those normal kinematics that we need for healthy motion. What you'll see in your patients moving through a forward bend often is that their mid and upper lumbar spine will move in block, meaning that you're not going to see that nice segmental motion. So if we want to just really make sure that we're treating them, we can do joint mobilizations at each segment to make sure that we're gaining the motion that we need. we can start to gain a little bit more understanding that as we go through this, we're going to get flexion of our lumbar spine, but then we'll also start to get anterior tilting of the sacrum. And that anterior tilting of the sacrum allows for more motion to occur. When we measure our lumbar, quote-unquote, range of motion, we actually measure it with the thoracic spine involved. And that's because we know that really in function we don't separate out the two, or it's rare if that occurs. We'll use the following ranges for your thoracolumbar motion, and this should tie well into your foundations course. And so this is just something I want you guys to just know that there's a significant range that it should be. We should see patients that maybe can go up to 80 degrees of flexion, 25 degrees of extension, lateral rotation 35 degrees, lateral flexion 35, and then rotation 45. And rotation, I just want you to understand that really coming from the lumbar spine literature has been very varied, from that the lumbar spine contributes only 5 degrees up to maybe 18 degrees of rotation. And so it's very small in the lumbar region and a lot more in the thoracic region. So we can start to pin it together that, okay, my patient is having low back pain, but their rotation, their thoracolumbar rotation is only 10 degrees total. So are they getting more motion at the lumbar spine than they are at the thoracic spine? So we start to paint that picture of that kinetic chain is not working as it should. We're going to touch on Fryette's laws, and this is really so that we have just kind of a common language. But you know, in the next slide, we're going to just look briefly at this table of the literature review. And it's a difficult conversation because we're in school, we need to have some type of neutral language. So we're going to just come back to Fryette's law. So law 1 is when any part of the lumbar or thoracic spine is in neutral, side bending will be opposite the side of rotation. So if you guys take yourselves through that, so if we're in thoracic spine is in neutral, side bending will be opposite the side of rotation, meaning if I side bend right, I'm going to rotate left. Law 2, when any part of the spine is in flexion or extension, rotation and side bend will occur to the same side. The cervical spine will always follow law 2. So when we look at that, so if we go through flexion, we're going to think about that I'm going to rotate and side bend to the same side. So just keep that in mind. And then law number 3, anytime a spinal segment moves in one plane, it diminishes the potential for movement in another plane. And this is true of all of our movement. So if you think about not just spinal mobility, so if I'm going to bend forward, I'm going to diminish my axial rotation and my side bending. But what we're coming to understand is that we often will always see some type of motion in all 3 planes. Okay, so to add some more muddy water to this was a systematic review, and it just looked at all the different literature out there, looking at if there's coupling motion occurring, which direction the coupling motion is occurring. And what I want the take-home message to be is that the takeaway is that it is so varied and that it is very individualistically based. And so when you watch someone go through motion, what you're going to do is you're going to see if there's too much abnormal rotation, and then you're going to start to gather more information. Are they having pain on that side with compression? Are they having pain with gapping? So really what is occurring, and start to pin all that information together. So I want you guys to just understand that it's very individually based. But there is, with side bend and rotation, there's always a coupling motion that occurs with that. So kinetics, we've talked about this in the earlier sections of the axial spine, but the 2 big ones for the lumbar region are compression and shear. And so compression is, we know that the vertebral body is big. We know that it's there to take the weight of the body, and that there's a lot of tension put on that because of all those attachment sites of our soft tissues into the area. What we start to paint the picture of, though, is if we have someone who is maybe a bodybuilder or for their work environment, or they have gained significant amount of weight. That all of this adds so much compression into that area. And that is part of our job, right? Is to look at the way someone moves, but also talk to them about what are the other extrinsic factors or even intrinsic factors contributing to the increased compression of that spine. Our bodies are made to take a lot of load, but when we add on extra mass, this can really be detrimental to that. The second one is shear. So shear, when we're talking about that the shape of the facet joint orientation, and that the facets really are there to stop shear. And so that we can start to see that if we have repetitive stress, maybe through an ADL or through occupational habits, that we gain compromise of those zygopophyseal joints. And we start to see maybe some micro fractures happen into that area. Or if we're getting increased pressure through that area that are really our connective tissue. I'm really trying to work on this pen, but it's not working. So connective tissue is really can really be compromised with that. So sorry, this was supposed to be a C, but it's not. So we'll just keep going with that. Okay, guys, so we're really going to just wrap that up. Those are the big take-home messages for you guys. And then we're going to cover what happens with the sacral region, so meaning the SI joint and the sacrum, in a little bit more detail together in class.